So thank you all and welcome to Public Health 101. My name is Nafla Poff. I am the Prevention Capacity Building Specialist at IowaCASA. Today, we're going to just be doing an overview of public health as a field and some of the principles behind it. I also wanted to just say thank you. This is my first CE presentation for IowaCASA, and so throughout the presentation, if you need me to slow down at all, especially for closed captioning, or if you have any questions, feel free to put those in the chat or the Q&A. Also, I just wanted to give you a little bit of background on who I am and kind of why I am giving this presentation at all. So I have been in or around the public health field for about 10 years now. I've worked in the infectious disease area of public health, working on tick-borne illnesses and mosquito-borne illnesses. I have worked in chronic disease prevention around breast cancer, cervical cancer, and colon cancer prevention. And I have also been involved with maternal and child health, including health equity, and then prevention of infant mortality and a little bit of maternal mortality, as well as working in the systems field. Throughout all of those, I've also worked at the state, county, and nonprofit levels. So I am not an expert, but I do have a fair amount of experience working in public health and different sectors of it. So hopefully today I'll be able to give you a well-rounded overview of public health. And also at the end of this, I will be providing the link to the evaluation. So if you would be so kind as to evaluate me, be as blunt as you would like to be. This is, like I said, my first CE presentation. So I would like all of your honest feedback so I can make sure that I am doing the best that I can for all of you. Also, you might occasionally hear some little cat chirps. I do have a cat here today, and she is being a little bit vocal right now, so I apologize for that in advance. Oh, she's bringing me a toy. So anyway, thank you and welcome to Public Health 101. Yes. So today we are going to go over an overview of public health. Yes, and if there may be a cat sighting, there's at least some audio for you. So we're going to go over an overview of public health. We're going to talk about the public health approach, go through a real life example of said public health approach, discuss our local health departments as well as kind of the system as a whole, and then a quick summary and any questions that you may have. And throughout this presentation, like I said, feel free to put any questions that you might have in the chat. I might answer them in real time. Otherwise, I will do my best to address them at the end of the presentation. Evie agrees. So what is public health? So academic definition is the science and art of preventing disease, prolonging life, and promoting health through the organized efforts and informed choices of society, organizations, public, private communities, and individuals. And this was a definition given to us by CEA Winslow, who was an American bacteriologist around the late 1800s and the early 1900s. Public health has been around for several centuries, but really in the late 1700s on, it really began picking up steam as we began to understand and we began to understand bacteria more specifically, and then viruses at the turn of the 20th century. And then also as our technology improved and our ability to use the public health approach I'm going to talk about next, it really became a more robust practice. And so I like to think of public health kind of, we think of doctors very much like crisis response. You break your arm, you have a problem, you go to the doctor, they fix the problem. Public health, for all its merits, it's a struggle to be in, because oftentimes in the work of prevention, if we're looking to prevent disease or prolong a life, with that same broken arm example, if my public health approach is working, you shouldn't be breaking your arm, you shouldn't have a need to go to the doctor. Yet proving to someone that you could have at one point been injured is kind of difficult. And so when we're not really going to touch on funding or anything like that today, but a lot of the reason why funds aren't given to public health is we do struggle to prove that we are effective at stopping problems before they begin, because oftentimes if we don't have clear data, it's just a bit of a mess. So this is just a brief list of all of the spheres in public health. So oftentimes we think, when we think of public health, we think of restaurant inspection, or maybe OSHA and their worker guidelines. Public health is so much more than that. It's so much more than I have listed here. It goes from environmental health, which isn't just our conversations about climate health. It does include that, but also your own physical environment. So that's where we have well inspections or radon testing for your home, or even those restaurant inspections that I mentioned earlier. We also have the more disease-related portion. So chronic disease prevention, infectious disease prevention, and then oftentimes kind of folded into that are maternal and child health, which has a wealth of areas within it: children and youth with special health care needs, women of reproductive age, children, infants, and then also just any other person that might have an interaction with a mother and or child or be involved in their lives. And then we also have things like emergency preparedness, which if we're hosting a large event, so for instance, it was just recently announced that Des Moines will be hosting the US Olympic trials for skateboarding, which was pretty exciting. But it is a large event. We're going to have a lot more people than we have the last year kind of flooding into Des Moines, or even something like a state high school basketball or wrestling tournament. There's this large influx of people, which means that there's a large influx of potential diseases or illnesses related to, food not being cooked, or say there's a natural disaster. We need to be able to have plans and know how we're going to address those issues before they come up. And so, for instance, I used to work for the state of Wisconsin, and we were supposed to hold the Democratic National Convention in Milwaukee. And even in Madison, we were beginning to prepare restaurants and hospitals for the Democratic National Convention about a year and a half in advance. So we were able to ensure that if there were any needs that arose in that period, even though Madison is an hour and a half away from Milwaukee, everyone was prepared. And then we have where our work fits in. So violence prevention, and also in the injury prevention world. So like I said, this is not a comprehensive list, but I'm just trying to show that public health is much larger than we think of it. And I think we can use that to our benefit in the future. So the public health approach. And one thing that I want to acknowledge before we really dive into this is right now I have it as a straight line, but really the public health approach is not even truly a cycle, but you will loop back several times. You might jump forward and then loop back again. And so it's not a perfect circle. It is not a linear process, but this is a good way to think of it, at least in the beginning. So oftentimes we have a problem. So just for a little thought exercise, we'll say there's a measles outbreak in Northwest Iowa. And so we have to begin doing surveillance. You know, our hospital systems may note in a little rise in measles cases. Same with any reporting that's done to the state. For a little while, it'll, you know, we'll see little blips, but we're beginning to be concerned about this little rise in measles. So we have to say, is it a problem? Is this really going to keep going up? And when we say yes, then we have to figure out what the risk factors are. And when I want to go back to that word surveillance, it doesn't necessarily mean that public health or hospitals or the state or the government are watching you, but they're watching the data. So when hospitals have some reportable diseases such as measles, or in some states, tick-borne diseases, they will get that data and be able to have a general idea, or obviously COVID, have a general idea of the rates of disease at that point. This surveillance also includes problems that might not be as real time. So we might look at like a chronic disease where you know that there's going to be a base level, and one person being diagnosed one day isn't necessarily something that's going to cause worry, or even 100 people. But if over time we're seeing that more and more people just keep being diagnosed, then we notice that there's a problem. So I know we don't love the word surveillance, especially with its connotations around just being watched and law enforcement, but it's not us as individuals that are being watched in public health, but more the disease and the number of people that are being affected. So we move on to risk factor identification. So what is the cause of this measles outbreak in northwestern Iowa? So we might note that for a little while now, our vaccine rates in that portion of the state have also been going down. And so we might say, okay, fewer people are getting vaccinated and fewer children are being vaccinated for measles. So then we have to move on to intervention evaluation. So we ask ourselves, what works to fix this problem? We've already seen that there's been public service announcements that constantly go out about getting your child vaccinated. And we know that to go to public school, you have to have vaccine records to have your child in school. So there must be something that we're missing. So we have to ask ourselves, maybe we just need to work with the community more, have conversations with them. So we send people in and we learn that it isn't necessarily that people don't want to be vaccinated. They're seeing or don't want to vaccinate their children. I'm sorry, but that they just have questions, and the providers that they have access to aren't answering the questions in a way that they want. So then we decide our implementation should be talking to the providers and being sure to update the fact sheets that you get out, that you're given when you have a vaccine. So based on what I have right here, that would be the end of it. Yay, pat ourselves on the back, we've fixed it. But really what we need to do is go back all the way to the beginning and say, continue our surveillance. So we've updated our fact sheets for doctors. We've encouraged them to have more honest conversations with the parents of the children that are being vaccinated. And then, are we actually seeing any change? Yes or no? If the answer is no, then we have to go back. We have to say, okay, that implementation, that intervention didn't work. So then we have to ask ourselves again, what works? And oftentimes, if it's a new problem, similar to COVID, our first risk factor identification is often immediately before the issue. So we're saying, wash your hands, this individual risk. But really what we want to do is continue to move further and further back. I know many of you have seen Kelly Marie's presentation and talked about primary prevention. That is applicable here as well. So we really want to find what that initial risk factor or that initial group of risk factors are, move as far back as we can. So an example, I want us to time travel just a little bit back to the early 1800s London. At this time, thousands of people were dying from cholera. And at the time, popular opinion was that cholera was caused by bad air, also known as miasma, coming from rotting organic matter. So at this time, if you had any waste, be it food waste, animal waste, or human waste, you just threw it out the window into the gutter in a certain, anything, it wasn't in your house, it was now in the world. So London did not smell very good, or so I'm told. I was not there, but sorry, just check it out. Yeah, I see the question, is this a webinar for domestic violence or sexual assault? This is for sexual assault prevention, but also just an overview of public health. And I will tie it into sexual violence later on. So thank you for that question. So at the time, London was not a very sanitary place as we think of it now. And also at the time, there was a theory called miasma theory, so that bad air theory, that most diseases came from breathing bad air. And so if London didn't smell very good and there was a lot of bad air around, it fed into the theory that that was what was causing cholera. However, not everyone believed in miasma theory. At the time, bacteria theory and like the germ theory has been around for thousands of years, but not in the way that we think of it now. And it was really just beginning to take off at the beginning of the early 1800s. And so it wasn't completely unknown, but it wasn't really what people thought of. It wasn't until around the 1850s that miasma theory fell away and germ theory moved forward. So this man, John Snow, great name, believed cholera was caught by drinking contaminated water. He noticed some clusters of cases throughout the city. He would track them as they popped up. And he did what we call shoe leather epidemiology, in that him and some team members walked around London and interviewed cases and their family members. And what it revealed was most cases were near water pumps, the biggest cluster of cases being around the Broad Street pump. And there were some outliers, as we call them. So people that didn't fit this pattern of living near a water pump or live near a water pump and weren't being infected with cholera. So one such person was this woman who lived way in the outskirts of town, and she had cholera. She was suffering from cholera. They couldn't figure out what her tie to it was. So they didn't quite walk out to her, use that shoe leather epidemiology until a little bit later. And then the other outlier was there was a brewery right next to the Broad Street pump. And nobody in the brewery had cholera. And again, it didn't quite make sense. I mean, you live near it, what's going on? So John Snow kind of tracked everything down, gathered a bunch of data. He did this surveillance. And then he identified the risk factor being living near a water pump. So then he did his intervention evaluation. He removed the handle from the Broad Street pump. And lo and behold, cases started dropping because people weren't able to use that well for water and had to use other, spoiler, non-infected wells. And this drop in cases gave him the leverage that he needed to be able to fight with politicians and the water companies that the water was contaminated with sewage. And that was the source of the cholera outbreak, as well as a lot of other waterborne diseases. And this resulted in the implementation of water sanitation policies and laws in London. And so huge cleanup, cholera rates dropped. It's a very, you're not going to get cholera in London anymore because of our sanitation and policies and laws that we implemented from this. And also with those outliers, the older woman that lived far from the pump, turns out that Broad Street pump water was her favorite. And her sons would walk miles carrying water for her because she said it had just like a slightly sweeter taste. And that brewery, they just drank beer all the time. They'd take it home. And that process, yes, they used Broad Street pump water for their brewing, but the process of actually brewing the beer and the alcohol itself was killing any cholera contamination. And so it kept them healthy. And I just always thought that was a fun little fact. So really, we've come quite a long way in public health, in just our understanding of disease and cause, and our ability to kind of work through a problem. Now, granted, we are not always very efficient in public health because of our lack of data. As we know with sexual violence, our data isn't reliable. And especially when we're trying to gather the primary prevention data to be able to prevent sexual assault later, having someone go through various risk factors in their life, especially if they don't see themselves as victims of assault or don't see themselves as someone who needs or who should report, or they don't want to, report it at all. It does give us a lot of issues, but we are getting better. And, with the invention of vaccines, we've been able to eradicate various diseases. We're on the verge of getting rid of polio. We're on the verge of getting rid of guinea worm. It hasn't all been good. We can definitely acknowledge that, but we have come a long way and we are continually learning. So what does this have to do with sexual violence? I mean, we work in a system that is being supported by public health right now in certain capacities. And as the anti-violence field grows, it's beginning to borrow more and more from the public health structure. And that has benefits and has negatives, but especially in prevention, almost everything we do, all of our funding comes from the CDC, the Center for Disease Control. And so it's already built in that public health structure and often using that same way of thinking. So there's a problem. What are the risk factors that cause that problem? How do we approach and how do we fix that problem? And then implementing and then continuing to evaluate. And so I believe that as our field grows, it's only going to get closer and closer and closer to that public health theory. And we've already started doing it. So many of you may have heard of connecting the dots. That this is a document that's put out by CDC. I have the link at the bottom, but also if you just Google connecting the dots CDC, that is, you should be able to find it fairly quickly. And this talks about risk factors and protective factors for different types of violence. So it has intimate partner violence, it has suicide, bullying, sexual assault, as well as a few others. And I also want to share that, while these risk factors and protective factors are linked across anti-violence work, they're also linked within chronic disease work and within reproductive health work and within maternal and child health. And so as we move forward, thank you, Kelly Marie, for sharing the link. As we grow, I would like to see especially prevention beginning to work with other public health fields, because public health as a movement is also beginning to acknowledge that it shouldn't be the burden of the individual to change. It's the burden of our communities and our societies and the structure and the systems that we live and work in to push us forth towards having fewer diseases, living longer, healthier lives. And it's not us as individuals that need to change. So some of the risk factors for sexual assault are harmful social norms, community violence, poor parent-child relationships, and poverty and lack of opportunity. And I would like to say that these are risk factors for perpetrating sexual assault, not be the risk factors for being sexually assaulted. Because really in prevention, that is our goal, is to decrease the amount of perpetration and the number of perpetrators. And then that will allow people we're reframing the issue, and that allows people to live free of the threat of violence. And so with the community violence, poor parent-child relationships, and poverty and lack of opportunity specifically, those are all areas that we talk about in chronic disease prevention and even in infectious disease prevention. So poverty especially affects so many things. Housing is another piece that has been coming up more and more, access to safe and equitable housing in conversations around infant mortality prevention and infectious disease prevention and chronic disease prevention. And I think we'll end up becoming a part of the conversations that we have as well. And same with the protective factors, community support and connectedness, connection and commitment to school, association with pro-social peers. So association with peers that also see themselves as part of a larger community, see that connection to and commitment to school or their community. And so we really are, we may not see ourselves in the movement as a part of this larger system, but I think that we are an invaluable piece of it. And the public health system should be inviting us as preventionists and advocates to the table because we have an understanding and have been working towards this for a long time. My cat agrees. So you all are lucky in Iowa in the sense that every single county has a local health department. How much they are able to do in their capacity obviously varies on the side, or on the size, my apologies, but every single county has one. And so I would like to encourage us as anti-violence aficionados and workers to partner with our local health departments. And I pose the question, how can we partner with our local health departments? And it's a hard question to ask a large group like this, because like I said, every local health department has slightly different focuses or slightly different capacity. But for the most part, they are trying to get to the same point that we are. And if we're looking at kind of the system of public health, we have the federal government and the CDC sitting at the top. Then we have all of our state health departments that kind of funnel in from there. And then our local health departments are the ones that really do the on the ground work. They are the ones that take the programs that the state health department thinks of, and then they make them work. And they also gather little bits of data from the county level, so then they can pass it back up to the state and hopefully make informed statewide decisions. I see a chat. Oh, thank you again, Kelly Marie, for sharing that. So as we partner with our local health departments, hopefully we'll be able to find areas where we may not see ourselves immediately, but I think we have a huge role to play and a lot of experience both providing support, but then also thinking in new and interesting ways about how to solve some of those issues and how to address those risk factors that we talked about a little bit earlier. And so the work continues. We have to not only advocate for survivors, but also begin to advocate for future victims and future survivors. And so we have to make the anti-violence field seen and heard. And part of that is introducing ourselves and opening ourselves up to a wider system. And so we've been great at that, but I think public health still often fails to see us. And yes, that is their problem to fix, but I think that we can have a role in it. So with that, if anybody has any questions, feel free to put them in the Q&A portion. I also have my email up there. Like I said, I am the Prevention Capacity Building Specialist. So if your organization needs help thinking of new and innovative ways to weave prevention into the work that you're doing, please feel free to email me. I am more than happy to work with all of you. Or if you have really any questions about anything, feel free to email me. If I can't answer them, I will try and either find the answer for you or help connect you to someone that can. So I'm going to stop sharing my screen for a second. I'm also going to put the evaluation link in the chat. So if you all would not mind filling that out, and please share your thoughts on my presentation with me and with the rest of IowaCASA training as well and technical assistance. If there are any questions that you would like to ask and you don't feel comfortable typing them out, feel free to raise your hand and I can unmute you as well and allow you to talk. Well, then with that, I will stop recording